Okay, welcome everyone. So far we have 22 participants that has logged on. Good morning to Dr. Allard, to Chris de Villiers, and to Tobias van Reenen. Once again to everyone so far that has logged in, warm welcome from a nice and sunny Cape Town. We are happy that you are here. We thank you for the time that you've taken to join us this morning. I trust and believe that you will find the session very valuable. I would like to ask our Managing Director, Chris de Villiers, if he would like to do a short welcoming to our participants this morning.
Thanks, Candice. And Dr. Allard, it's really great to see you. Thank you for joining us. Really appreciate it. Dr. Allard has had many experience with the Sanofi chest drain. So quickly, for those of you that don't know, I'm from Sanofi Biomedical. We develop medical devices, and the Sanofi chest drain is actually the first product that we developed. The development started in 2001, and in 2006, 2007, we started evaluating and selling it in the first hospitals in the Western Cape. Dr. Allard was actually involved from the start when he worked at Geefjeuster Hospital as a trauma surgeon in those times. Since then, I think by now we must have, Candice, I'm going to guess, 70% market share in South Africa with this drain. In other words, a dry seal chest drain has taken over from a wet seal underwater drain bottle that I think many of you would be familiar with. We export the same product and the same technology to about 40 countries, and the countries that we are quite proud of are hospitals like Zurich in Switzerland using, and I think we must be close to 20% market share in Germany. Austria is using, quite a few countries in Eastern Europe. South Korea is doing well. We sell it to Southeast Asia. We sell it to South America. So with the help of South African surgeons, with the help of South African healthcare professionals, the technology of a dry seal chest drain has definitely proven to be more effective in terms of treating chest drains. Yeah, we are looking forward to grow even further. But today, the main purpose of today's session is for new participants, new doctors, new nursing sisters to learn how to use the product. So I hope that you will learn something as we explain. Good.
Thank you so much. Thank you, Chris. Thank you for that word of welcome. Just to share, so within South Africa, we are currently, or hospitals currently using the Sanofi chest drain is in all 9 provinces. So it's being used throughout the country, and it's doing quite well. So okay. Also, just a note that we are welcoming both health workers from the public sector as well as the private, because the chest drain is being used in both private and public sector. I would immediately like to go on to our first speaker, who's Dr. Dennis Allard. I'll give you a short bio on Dr. Allard. Dr. Allard is a postgraduate surgical training, in Luxembourg, Belgium, and South Africa, specialty in general surgery from the University of Brussels, Belgium in 2000, registered as a specialist general surgeon in South Africa in 2006 after successfully participating in the FCS final examination, subspecialty in trauma surgery in 2008. Dr. Allard has been employed at the Geefjeuster Hospital in Cape Town from the year 2000 until 2011. He worked as a consultant at the trauma unit of Chris Hani Baragwanath Academic Hospital in 2012 as a remote site surgeon at the UNSOA. From 2016 to 2001, he was a trauma surgeon at the Christian Barnard Memorial Hospital in Cape Town, and is currently the trauma surgeon at the Rondebosch Medical Center. So Dr. Allard comes with a wealth of experience and knowledge, and we are very grateful for your inputs this morning. I hand over to Dr. Allard.
Thank you very much, Candice, and Chris. Great to see you, Tobias, and all participants. Do I share my screen already? Or the first couple of words is that chest trauma is very frequent, and you in the public service will see much more of penetrating trauma, and in private then or higher levels of trauma units you will see more blunt chest trauma. Broken ribs can also create an hemopneumothorax, and unfortunately one can die of a simple pneumothorax, hemopneumothorax, that then would develop into a tension hemopneumothorax, and so that is avoidable. And we with large amounts of chest trauma, and we saw 1,000 young, mainly males, that required a chest drain insertion for penetrating chest trauma whilst at the Menenberg Hospital over all these years. And the beginning years were always filled with those underwater bottles, where then the right liquid needed to be in, the right amount needed to be in, and when the bottle fell over, suddenly there was now air. There was no more underwater seal, but there was air that was going back and forth into the chest. So that was complicated and not ideal. And so when Chris approached us and we discovered the Zinapi drains, of course we were very keen to immediately try this dry seal with this Heimlich valve incorporated in a device. I mean, it is really quite ingenious, a simple Heimlich valve into a device, no more falling over. You can hold it in whatever direction, and whatever comes into this container can actually also be easily given back to the patient just with interposition of a little blood filter. And so that is of huge advantage. And so very keenly we went on board, and then the more you use it, the more you get used to it, because indeed it takes getting used to it to not anymore looking for, is the chest drain bubbling or not. Here you see, is the little Heimlich valve going to be angulated or not, and is this little is the little bulb that was later added, is that remaining depressed, yes or no? If it is not depressed, there's still air coming. Like now when I release the drain, then there's still air, an air leak, but as soon as it remains depressed, you know that you achieved already inside the chest a relative negative pressure, and so that is great. So how to insert a chest drain, and I'm going to share then with you. I'm going to share the screen, and that goes like this. Yes, can everybody see now? Can you see this, Mike? Yes.
Thank you, Dr.
With an intercostal drain. That poster, I decided to immediately, also teaching ATLS a lot, and ATLS instructor and course director. I mean, inserting a chest drain, it can go terribly wrong, and that's why the basic is one should still always stick to good basics. And you will see here on top left how do I insert an intercostal drain, or how to insert an intercostal drain, and it does say that the X-ray is not always available. You will not always have an X-ray available, and in massive chest trauma, where there is massive reduced air entry and an unstable patient, you will sometimes insert your drain blindly. But on that side, on the correct side, sometimes you will go on both sides. That is in the highly unstable patient, that is polytrauma, but most of you will encounter the simple patient with a penetrating chest trauma, you will have an X-ray available, and then you will see, is the whole lung collapsed? Is it partially collapsed? Is there fluid or not? And without now wanting to go into the details of when to remain conservative or so, you decided that you're going to put a chest drain into that chest. You have your sterile equipment. Yes, sterile. And with gloves, a pair of gloves, and the basic material must be there. As you can see, we inserted those chest drains in a small procedure room. You can put the patient on his side with the arm above the head, and you don't necessarily need to disinfect the whole chest, but you're going to clearly know where you're going to insert the chest drain. And that is at the nipple line, just anterior to the mid-axillary line. The mid-axillary line is a patient standing position. You would put your hands into the axilla, the highest point up, and then your hand is well positioned and is actually in the middle between the front of the chest and the back, and that is the mid-axillary line. And you're going to insert your chest drain, ideally just anterior to the mid-axillary line at the nipple line. That is going to be 5th or 6th intercostal space. And in that area, you will have the least muscle, and you're going to do it safely. So you're going to clearly disinfect, well, starting in the middle, going all around. And once that is well disinfected, you see, as is shown here on the poster, we didn't use, because we didn't have always fancy drains. This was in the government hospital, but you put a sterile towel there, and if you remain precise in what you do, then you're going to infiltrate. Skin, subcutaneous tissue, go onto the rib, and then walk your needle just above the rib and give a good amount of analgesic, of lidocaine, anesthetic, sorry, not analgesic, anesthetic, into just deep into the pleura and around there, because that is a sensitive point. So the skin is very sensitive and the pleura is very sensitive. And then having done that, you can now do an incision along the cochlear lines. Sorry if I now say cochlear, it's another line, the body lines, horizontal, that you're going to make your incision 3-4 centimeters. Don't make these very small incisions because you're going to struggle, you're going to cause skin necrosis, and your end effect is going to be a much uglier scar than what you tried to prevent. So a good incision, subcutaneous, you go deep, you use now a dissecting forceps, and you dissect bluntly. That way you're going to have the least possible bleeding, and you dissect bluntly until you go on top of the rib, and then you go just above the rib. Okay, so blunt dissection onto the rib, you go above the rib, and that's where, with a controlled fashion, you're going to now penetrate, because deep here is going to be the pleura, and there, once you penetrate, and that takes a little bit force, but you're going to be careful not to just go too deep, because you can damage lung structures, you can damage whatever's inside the chest if you're really, really rough. So you must be very careful. So on the rib, just above, and then again, spreading your instrument so that you will hear now a gush of air happening. Gush of air, ideally, that's what you want to find. If now you did that, you didn't really have a gush of air, you're going in with your finger. Next is with your finger. You create a nice space, your finger must follow, and it must be able to feel inside the chest cavity. There's the rib, and there is no lung. So your finger must be able to go all around, above the rib, all around. If at that moment you feel that there is no space, that you feel that there is lung, and it is not collapsed and it is stuck, don't continue. Go back, you get your x-ray, because that lung is not collapsed and that patient will not profit from having a chest drain on that side. I don't say there is not somewhere some fluid or some air, but this is going to be a much more difficult chest drain. So at that moment, it needs probably something more, and that is beyond what we're going to do here. So once you did your finger thoracostomy, and if it is a very unstable patient, you now created that, and you actually released whatever air was inside the chest cavity under tension. So you would have relieved by now the tension pneumothorax, and in a very unstable patient, you can do that on both sides. Yes, a drain will follow, but if anything else needs to happen, it can happen now. If you now insert your chest drain, use the biggest drain possible. I do recognize that as things evolve and our knowledge evolves, we used to be always, I used to be very dogmatic, a big drain to drain blood. I would now say that a 28 French, which is a smaller drain than the 32 French, but the 28 French is probably enough. That said, the fresh blood in the chest, that is the moment when you try to get all your blood out. And you're going to insert your drain without a trocar. Don't use a trocar. I think that by today, all the chest drains with a trocar will have been taken off the market. Because these trocars, where the point was very pointy and very sharp, were very dangerous, and they can go deep and into a lung parenchyma, and the drain inside the lung parenchyma is also going to be possibly a death sentence a couple of days from now. So a drain, no trocar in it, you guide your drain. Inside the chest, the drain is not necessarily going where you want it to go. So if we say go upwards and backwards or downwards, like other trauma surgeons will say or teach, going downwards into the direction of the diaphragm, not bad. If the drain points upwards initially, that's all you can achieve, because it is not really feasible to have the drain go where you want it to go. Now your drain is inside the chest, and you have on the drain fogging of air, because the warm air from inside the chest cavity will create fogging on that chest drain that is not at the body temperature. And then you need to take care that the holes that you see on the chest drain, and here's the chest drain that is already naturally curved, and you will see that there's these holes from the tip, and every drain will be a little bit different. So just see where your last hole is. Here is now the last hole of this chest drain, and at that moment you want this part here should be at the skin level. Okay, so give it a good 5 centimeters. In obese patients, even more. You need the last hole to be inside the chest cavity. The last hole is often on the radio-opaque line, so that on the chest X-ray you can see the interrupted radio-opaque line. That will be the last hole, and now you have inserted it well into the chest, and you're now going to start attaching it. And to attach it, you do a purse string suture. Take a big needle, a big 1 or 1 0 or 2 0 on a Colles needle is fine, and you go all around and you create that purse string suture as you learn in medical school, and then try and do no harm and don't start making half knots. Okay, half knots at this level. Remember, us in private, we remove our own drains, and then we know exactly how we did it. But out there in government, you will not, almost surely not be the one that removes your own drain. So make it simple for the one that will have to remove it. That's why after a simple purse string, you will have both ends, you cut off the needle, it makes it less dangerous, and you now twirl it around so that it creates a little twirl at the level of the skin. No half knots, because in a couple of days while you remove it, it will be easiest to just undo, and then you have still 2 long throws, and after the drain comes out, you can easily then throw a half knot to close that wound. So you then go all around like a Greek shoelace, and you do that with all the lengths that you have available, and then at the end you create a good strong knot, and make sure that your drain is well attached. That is so important, because any drain that where the patient moves in bed and it gets stuck and it comes out is a potential for a patient then again dying of a tension pneumothorax, because the original injury to the lung will not yet have healed. So a drain, if it's needed, you put it in safely, you attach it safely and strongly so that it doesn't come out, and then you will make a nice dressing. The dressing is your signature. You try that there's not blood coming out, and you connect your drain to an underwater bottle, and this will be where the Zinapi drain comes in. So also make sure that so this what I'm holding in this hand is the Zinapi drain. You see the connector, and you see that here any chest drain has then anything. This is an Axiom 32 French, and you can cut it, whatever, but try that this connection is nice and strong. Okay, nice and strong together. So now it is connected to this underwater drain, and the whole drain then is comes into this. That is the Zinapi drain that you then hold, and you now just need to watch that. You will see blood coming out through this tube, and what you then do, you do this. You depress this bulb several times, and that way you actually suck. It has a suction effect of removing air and blood from the pleural cavity, from the chest cavity. Okay, so once your drain is then...
Dr. Allard?
Yes?
My apologies. Are you showing the drain right now, or are we still looking at your poster?
We can...
Are you showing the drain?
I can... Yes, does not everybody see me? Okay, sorry. I'm going to stop the share.
Thank you.
I'm going to stop the share. Okay, sorry, so what I showed was the drain. I showed the drain, and here's the last hole of the drain, and you want it to be inside, deeper than the rib. So this level will be at the skin. Does everybody see that? Are we good now?
Yes, doctor, thank you. We're good.
Yes, so at this level, at the skin, this is your chest drain. So you inserted your chest drain, and you will see the fogging coming in here, and at the end of the chest drain there is, and now inserted it well. So a chest drain at the end is having an end like this, and you can cut it, and there's a connector. The connector is usually on the chest drain. This is the chest drain. The chest drain comes in a package like that. Your chest drain is separate. The chest drain is not made by Zinapi. There are several chest drains. Your hospital will have chest drains of different sizes and different quality. Chest drains must never do that inside the chest. They should not easily just break, because then they block. So a chest drain is made of a consistency that it will not obstruct the inner lumen of the chest drain. The Zinapi drain has a connector, and then this connector will go very strongly on the chest drain. Sorry, I had demonstrated that, but I wasn't aware that you weren't seeing. And then this whole device is the Zinapi drain, which now you did your dressing. No, everything here is sterile. So from inside, everything that comes, the blood that comes through this chest drain, through the tubing, and runs into this container, all that blood is sterile. And as I said, at that moment, you depress this bulb several times, and you ask your patient, if it's a patient with not a polytrauma that is on a ventilator, but now a penetrating trauma patient, single stab into a chest, who gets a drain, that patient will be, you give him good analgesia, and you ask him to take deep breathings, deep and coughing. If patients sometimes have a lot of pain in the chest, at that moment, a good trick, once the first blood and air came out, is to add some lidocaine into the drain. It's a wonderful trick. Lidocaine in normal saline into the drain and closing it a minute or so, because that lidocaine will immediately infiltrate the whole pleura that is around, that is touched by the drain, and that gives an instant relief, and it lasts long and can be repeated every couple of hours. But now back to our drain, and so here's the Zinapi container, and once how do you know that inside the chest it is, the negative pressure is re-established, is if your drain bulb remains depressed. Okay, your drain bulb remains depressed, your Heimlich valve angulates, and that is when you will have restored negative pressure in the pleural cavity between the lung and the rib cage. Okay, and then so the blood runs through here, it accumulates here first on this side, and then it can it accumulates in the whole drain. Now, because everybody until a couple of years ago was so used to the wet drain, the underwater drain, that's why there was this obsession on bubbling. And what the Zinapi engineers did, Chris and his team, was to then modify the drain. This was not available in the first drains that we tried in 2006, but then afterwards this little inner chamber came, where you can then add, to detect an air leak, fill with 20 milliliter saline. And this is a needless port. So you're going to take a syringe, 20 milliliter sterile water, and you're going to put it in there. That now creates a little air fluid level here, and then you will see your bubbling. That is for in case where the Zinapi drain Heimlich valve remains non-depressed and the valve is still straight. Then you will see, and you will be able to appreciate how much is the air leak. And you will then have a good evaluation of air leaking out of your injured lung. And yeah, and at that moment, if there is, here on the side, you see another scale of 180, 60, 40. That is, if you have very little blood, you can hold it sideways, and then you can appreciate how much the blood quantity is per 24 hours. Initially, most of the time removing a chest drain when it's less than 50 milliliter, but sometimes you will have then to wait a little bit longer. Less than 100 milliliter per day should be okay. Remember, any blood that stays in the chest cavity, and sometimes not everything, or often not everything, gets removed by the drain, and that then will become a retained hemothorax, and that retained hemothorax, that clotted blood, it will fibrinolyze, it will then attract water, and the quantity can become more. So often a very minimal hemothorax can increase inside and become an important hemothorax after 7 to 10 days or longer. What I then do, I then use my radiologist, and we then go and put a drain in, also connected to Zinapi, but that is then a very smaller, fine drain, not anymore our big trauma drain, but it's an ultrasound guided insertion of a pigtail drain of a smaller size, but directly into that collection, and that often resolves the problem. And then you ask your patient, if your patient is penetrating trauma, simple, and he can walk, then he should mobilize, and chest physio is important. Analgesia is very important, so give your patient everything that they need, and the patient is right, but that's beyond the talk here. But good analgesia, good chest physio regularly, and then you monitor your drain daily for what comes out. And let's not go into more detail. This is not for thoracic surgeons, but which I'm also not. I'm a trauma surgeon, but I would then get the thoracic surgeon colleague involved if there is ongoing air leak despite 2 drains, and it becomes difficult, then one can ask for help, or you call somebody else with more experience. Okay, so I think that is so far everything from my side.
Thank you so much, Dr. Allard. That was very, very informative. We really appreciate that. We do have 2 questions. Now seems like 3. I just want to address one question. One of the attendees has asked about a manual for the drain. Just to inform everyone that each drain does have an IFU in the packaging. So, but if the information on the IFU is not according to your question, you're always welcome to contact us, and we will address your question directly as well. Dr. Lott, the first question that comes from one of the anonymous attendees, I think you are, yeah. Do you perform intercostal drain insertion under ultrasound guidance?
And I now typed an answer and it says,
Yeah.
no, that I would, that becomes, you need then several people. I sometimes would help the radiologists, but the radiologists are, they are then very good. I like to be there and assist whenever I can, but the radiologists will be very good at exactly seeing where the best point is to insert that drain. So in trauma, we do it for the acute situation, and that is blindly, 5th intercostal space, 5th or 6th, above the nipple line, just anterior to the mid-axillary line.
Thank you,
I see here,
you may.
Any differences in terms of location for insertion of chest drain to evaluate air or fluid? Are there any differences in terms of location? Insertion to, to evacuate, okay. Yes, okay, so the live answer to that is that a simple pneumothorax in a patient with emphysema or bullous emphysematous disease is a different ballgame. He will have almost no blood and he will have air. And his air will be accumulated on the top of the lung. Sometimes all the way down. Rarely, I haven't seen somebody creating a tension pneumothorax, because that is a bullous on the surface. And there, yes, chest drains can be inserted in the subclavicular area, and there it is then. So in the COVID era, when those lung diseases created pneumothorax pure, they would get a drain from the front. Again, it's maybe, and then yes, the Zinapi drain remains the same. So whatever chest drain you insert, Zinapi drain is your friend. That drain that you will insert will then be percutaneous. Lately now, often the ICU sisters, when you ask for drain, they come with an already made device, and that is a device that has that is much finer, longer, and it has a trocar. That trocar is also still dangerous. So, but in that one, the trocar is more necessary, because if you place your chest drain for an apical pneumothorax, or that would not be traumatic, let's say, often ICU doctors place chest drains here, and that percutaneous pigtail or another type drain, not pigtail, will have a trocar. That is correct. Be very careful with it. But once that drain is in, with that connector, it will come to this, still to this part, and then you can, so the Zinapi drain is the same. Next question, what else was there? When do you put lidocaine into the chest drain? Not regular, I try not to introduce anything into the chest drain, but for patients who really declare a lot of pain from the drain, lidocaine into the chest drain is a good solution. And then there is Do you just put a needle in because now you created a hole, or you disconnect and then you add it, and so on? At that moment when they were very painful, I close a drain like this, and I would have it disconnected and then sterile lidocaine in it, and you reconnect it, and then you let the lidocaine you hold it high, you let it get into the pleural cavity. That helps. Can the Zinapi drain assist in knowing whether the lung will expand or not? So will the lung expand or not? No, there is no crystal ball attached to the Zinapi drain. So, but if your Zinapi drain shows that there is constant bubbling, constant bubbling when you have breathing in and breathing out, there's constant bubbling, that is a massive pneumothorax, that is a massive lung laceration, and at that moment usually a second drain, and then suction added to it, and then wait and see, and if the patient needs ventilation, and then getting maybe a thoracic surgeon or referral or somebody higher level of knowledge involved. Are there any differences in terms of location for insertion? Yes, I answered that. Can the Zinapi drain assist in knowing whether, okay, do you have a poster for patient education? We do have, yes, and I see here, so email us for more information. We have the poster that was made 2007, but it's still even with an old Zinapi bottle. Like I said before, it was technically improved, so we will also make a better redo a poster. That's on the to-do list. Over.
Wonderful. Thank you so much. Thank you, Dr. Allard. That has been very, very informing as well. Thank you for the participants who asked the questions. We all learn a lot from the questions being asked. It is now time for us to move on to our second speaker. Let me just get all the information. Dr. Allard, thank you so much. That was really, really good. Let's get our second speaker on. Participants, I would like to introduce to you Mr. Tobias van Reenen. In 2014, the degree of B Engineering in Mechanical Engineering was confirmed to Tobias by the University of Stellenbosch, and thereafter he continued his studies part-time and obtained his honors degree in 2020 through the South African Theological Seminary. Tobias has a robust understanding of the global medical device market. He has 7 years of experience in leadership and emotional intelligence development. In his 4.5 years at Zinapi, he gained experience in 3 different departments, of which one is engineering as a production manager, managing 100 people in primary, secondary, and tertiary manufacturing. Tobias was also our local sales manager, where he worked with business-to-business sales and has a good understanding of the complex medical device market here in South Africa. At the moment, Tobias van Reenen is our international sales manager, also working with other businesses and distributors, and is strategically growing Zinapi and our business with a global presence. Thank you for attending this morning, Tobias, and thank you for addressing us. We look forward to learning something from you as well.
Perfect. Thank you very much, Candice. And yeah, good morning, everybody. It's a privilege to be here, and also good evening if you're joining for tonight's session. Just first, Candice, I'm not sure where you got that bio. I would have wanted to make it only like 1 or 2 sentences, but nonetheless, it's a privilege to be here. And Dr. Allard, it's always good to just hear from your experience. You are one of the doctors that has the most experience with the Zinapi chest drain. You were there at the start in 2006, and just thank you for being present and sharing your knowledge. So this morning, I'm going to do a little bit of training on the Sinapi chest drain, but I'm going to look at specifically the topic for today is early decision making specifically. So let me just put it in slide mode. So just where chest drain development started, it's currently a lot of institutions still use a one bottle system in South Africa and also in many other countries that we work with. You all know the system, it's a water seal system. It works, the technology is more than 150 years old. Earliest literature that we can find was published in 1875 for the technology. So it is very, very old. It works 100%, but there are better technologies available in the current age, and Sinapi is one of them. Some of the challenges of the water seal system that you've all experienced at some point, it needs to be lower than the patient. It needs to be upright at all times, like Dr. Allard also say, if it falls over, there's no more seal, so air re-enters the pleural space and the lung recollapses, and you set back the patient recovery with sometimes a day or two. Which is quite critical, especially for hospitalization costs and also bed availability in certain settings. There's also challenges like when you want to mobilize a patient, it's hard because you don't want backflow of fluid to the chest. So often you have to clamp the device, and then you can't forget to unclamp the device because that can lead to a tension pneumothorax. You can't give the blood back to the patient as well. That's also a big downset. So the blood that drains in the container, you can't give it back. And then it started to develop in time to a 2-bottle system, splitting the collection chamber and the seal chamber, and then they added a 3rd bottle for suction regulation, all water seal systems. I'm not going to speak too much about the 2-bottle or 3-bottle, but it evolved from 1 bottle to 2 bottles to 3 bottles, etc. But we 100% believe that this was not the adequate evolvement of technology in chest drains. We fully believe that the best way to treat a patient that requires a chest drain is with a dry valve that's located before the container, like with the Sinapi chest drain. The Sinapi chest drain, the heart of our product is our valve. Like Dr. Allard said, it's a dry valve, it's a flutter valve, it's a one-way valve. Anything that goes through cannot return. And for this, allows the device to be freely orientated because it's not dependent on orientation to be upright, like with the water seal system. And in this in itself enables patient mobilization really easy and quickly. It's also a lot more effective to regenerate intrapleural pressures than a water seal system. There's many studies that's been published on dry valves versus water seal systems. So it is more effective with regenerating the negative intrapleural pressure. Our valve also, it never blocks. We often get that question, does it block, does it not block? Our valve cannot block. We've manufactured and tested more than 1 million valves since the start in 2005, and it does not block. Obviously, if it could block, we wouldn't have launched the product because that would have been one of the biggest risks. So we made sure 17 years ago that is not possible. And also with our valve, you don't require any clamping, which in itself also is safer and easier to use. So with our product, we've got 2 products. We've got a product with a suction regulator, where my mouse is now, and one without a suction regulator that's available in South Africa. So it's a dry seal, dry suction device. Today, I'll focus a little bit on 2 benefits. Like I said, the second one is early decision making, and the first one is early mobilization, early patient mobilization. With chest drainage, the quicker you can mobilize a patient, the quicker that they will recover, because the mobilization has a big effect on their tidal volumes and on their breathing. And obviously, with your diaphragm moving up and down more and quicker, it enables faster evacuation of the fluid and air. So you want a product that enables early mobilization for the patient, and then in itself, you will discharge the patient faster. And then the second point will be on just early decision making as well. So early patient mobilization, like I said, to adopt a protocol of early patient mobilization promotes greater tidal volume, which in itself assists with lung expansion and fluid drainage specifically. Globally, there's a big move specifically to implement protocols in all hospitals that focuses on early patient mobilization post-surgery or post-surgery or post any operation or insertion of a chest drain, if it's surgery or not surgery, but in trauma settings, as this, they've seen a big effect, obviously, with a lot of studies being published on that. And one of the committees that's really doing a lot of work in this space is the ERAS guidelines, the Enhanced Recovery After Surgery guidelines, that's contributing massively. So with the Sanapi, like I said, you want a product that's easy, safe, and free to mobilize a patient as soon as the patient can be mobilized. So with the Sanapi, it cannot lose its seal ever. You can put it flat on the bed like this video, so the patient can walk with it in the hand, not orientation specific. It's compact, it's small, it does not need to be on suction the whole time, or for a lot of patients never require wall suction. And it also, with the free orientation, enables easier nursing care with moving the patient around or repositioning the patient. So with this Sanapi chest drain, it's easy to mobilize a patient. And like I said, the quicker a patient is mobilized, the quicker the patient will recover. Second point on the early decision making. With the Sanapi chest drain, we provide visual indicators for the healthcare worker, the specialist, doctor, the nursing staff, everybody involved, all the stakeholders, specifically to give them extra indicators, extra tools to know what is happening inside the chest, what is happening in the pleural space. And we will specifically look at this red block here, the valve and the bulb. So with the Sanapi, absolutely look for fluids above the Scheffler valve. So in time, there will be fluids that accumulate here above the bulb. This is a very good sign. We often get first users that do not know that they should look for that. They think the valve is blocked. It's not blocked. And in the next slide, I will speak specifically about that element. And the second one, like Dr. Allard also highlighted really well, is you're looking for a compressed bulb. A compressed bulb will show that there's negative pressure in the pleural space. So looking for fluids above the valve. Here's a render picture of what you might see. And on the right-hand side is just a picture that obviously a drain connected to a patient. And this is a good sign. The valve is not blocked. What is happening? So when we look at it, I look at it obviously as an engineer, so very physics and scientifically kind of, but what is happening is the only way for fluids to be accumulating there is if there's two things. One, there's negative intrapleural pressures, negative pressure inside the thoracic cavity or in the chest. And two, there's no air drainage or no air leak. So immediately, if I see fluids accumulating here, I know what is happening at the tip of the catheter. There's negative pressure at the tip of the catheter, just holding the fluids there. And two, there's no air drainage or no air leak. A lot of our thoracic surgeons, that's in some other countries as well, they specifically look post-insertion of the chest drain. They look at how quickly they can see fluids accumulating above the valve. Because then they know the air leak or the air drainage has stopped. And then they'll monitor it over a period of 2 or 4 hours to say that they see now fluids there. Take the time. When they come back to the patient or nurse comes back to the patient 6 hours or 8 hours later, the fluids are still there. You know there's no air drainage that happened in that time. When there's air drainage, it will obviously just push out the fluids through the valve because fluid has a larger weight than air. So with gravity, the fluids will be moved through the valve. So this is a very good sign. For first-time users, look for it. When there's a lot of fluid drainage at the start, you will see this maybe a bit earlier because as the fluids drain from the chest, it creates a siphoning effect, which in itself is also good because it creates more negative pressure greater suction force for the rest of the fluids in the chest. And over time, as the pressure differences between the chest and within the atmosphere, the fluids will be drained effectively into the container, etc. This fluid is also not a lot. I mean, the whole bulb volume is about 25 to 30 milliliters, so it's not a lot of fluids. So it will have no effect on treatment, specifically with fluid volume. Yeah, so the fluids above the valve, it's a great indicator, and just be aware of it. Good sign, and it's one of the benefits, largest benefits of the Sinapi chest drain that we provide. Secondly, like Dr. Allard highlighted well, just quickly want to check it. The other side is quite bad. Candice, can you still hear me?
Hi, Tobias. You broke up for the last 10 seconds. We couldn't hear you well. Could you maybe just repeat the last 10 seconds? Okay, we got you back. Tobias, can you share your screen with us?
I am. I'm just changing internet connection.
Okay.
It's always, not always, but load shedding hits always when you're on a webinar or but nonetheless, everybody's got that challenge. Candice, please, just where did you lose me?
Tobias, it was where you started when you continued. Yeah, that's right. That's where we lost you.
Okay, great. Yeah, so the Sinapi bulb. So the first indicator is fluids above the valve, and it's an indicator to show the healthcare worker what is happening inside the thoracic cavity, inside the chest. And as well, the second indicator, like Dr. Allard highlighted, is a compressed bulb. When you insert the catheter and then connect the chest drain, you will press the bulb and it must expand originally because there's air, obviously air and positive pressure in the thoracic cavity. So then the bulb will expand, like Dr. Allard said. If the bulb expands, there's air drainage. Then nearing end of treatment, what you would see is when you press the bulb, you will see as this picture right here in this video, it will stay depressed. This also shows two things also similar to the fluids above the valve. One, there's negative intrapleural pressure. It cannot expand if there's not negative pressure at the tip of the catheter. And two, there's no air leak or no air drainage. So with these indicators, what it enables the healthcare workers to do is when you anticipate that the drain is ready to be removed or the patient ready for an X-ray, these indicators help you to make that decision faster when the patient can be sent for an X-ray, rather than with the water bottles. What we've heard from a lot of people, a lot of specialists and nurses, it's sometimes difficult to know exactly, you'll check the bubbles, but the bubbles only come, every half an hour, there's a few bubbles come through at the end of treatment, or every hour, etc. So it's hard to know. Then you also look at the swinging and the fluids moving up and down the tube, but it's hard to know like a set picture right now in the moment at this time. This is what's at the tip of the catheter. So with these indicators, it enables the healthcare workers to know immediately this is what's happening at the tip of the catheter. And when you anticipate with low drainage volumes, the bulb is compressed, there's a little bit of fluid above the valve, the patient is ready for an X-ray to be removed. We are also obviously doing, not obviously, but we are doing a study to look at the reliability of using the bulb and the fluids above the valve to remove chest catheters without X-rays. We obviously have experience with it for many, many years, so we're very confident in the study, but we need to just publish a study for the healthcare sector. So then just lastly, on the XS50, there's two products available in South Africa. On the XS50 Plus, this is the one without the suction regulator. This is on government national tender. So it's without a suction regulator. And on the other one is XL 1000 Plus that you can purchase on quote basis. It's got the suction regulator, dry suction regulator together. So on this product as well, it's very easy to use. We just call it a plug and drain device. You just plug it to the catheter and it drains. You don't have to add water. You don't have to keep it lower than the patient. It's really, there's no mistakes that can be done. It's got 1,000 ml capacity. When it's full, you drain it through the tap easily. There's no risk for opening the patient to infection because the Scheffler valve, the Sinapi valve, it's only one way, one direction, so it cannot return. And like Dr. Allard said, there's an Ehrlich chamber that you can fill with 20 ml of saline to see bubbles if you want to see bubbles. A lot of our doctors never uses the Ehrlich chamber. They don't use bubbles anymore. They just use the bulb that's staying compressed and with fluids above the valve to know that there's no air drainage. It's a far better indicator. Then with the product as well, we've got an auto transfusion port here at the bottom left, like Dr. Allard also highlighted, and this is to give the blood back to the patient. And then the auto transfusion protocol that we suggest on the Sinapi chest drain is another topic, but it's been used routinely for many, many years. And we've also did a webinar on auto transfusion with Sinapi chest drain earlier this year. But yeah, it is used routinely and it saves patients' lives. Obviously, like you all know, patient or blood availability is very scarce in some regions in South Africa. So with the auto transfusion port, we can safely give back the patient's blood. And it has been done for 15 years. It's not 5 years or 1 year, it's more than 15 years that we've been using this device successfully for auto transfusion. So I'm not going to talk now about the protocol on auto transfusion, but yeah, like Dr. Allard said, you will spike it with a blood giving set, which will have a filter in, and then yeah, you will be able to transfuse. Some doctors would want to add heparin, some not. I'm not going to talk about that right now because it all depends on how old the blood is in the device, how long it has been stayed in the device, etc. But we do have a protocol, and also Prof. Hartgasel from Inkosi Albert Luthuli did give his clinical opinion in a webinar on how he uses it. And yeah, so if you want that protocol, or you can email us and we will send it to you as well afterwards. Better that you hear it directly from the clinical expert. Perfect. Thank you. Yeah, that's all from my side. Like I said, it's easy device, it's a safe device, no clamping. You just connect it and then you use the bulb and the fluids above the valve to see what is happening at the tip of the catheter, to enable you to make clinical decisions earlier when the patient should go for an X-ray. Thank you very much for joining, and open to any questions.
Okay, thank you, Tobias. Wow. Wow. It's all that I can say. It's just very, very informative. And I can just think that our attendees and participants has also really found value in what you've shared with us this morning. We have indeed come a long way from the older technology, and we embrace the new, absolutely. We do not have any questions at this point in time, but thank you, Dr. Allard. You've shared your email address as well as your website, and I've also shared my email address. If any of the participants ever needs further information or would like to schedule in-service training with our various reps around the country, or just want to get into contact with us for some reason, please do reach out. We are always happy to hear from you. I do have Magda Botha. Magda would like to do a closing for us. Thank you.
Good morning, everyone. Thank you so much for attending this session. There's almost, I don't know how many webinars we've run since the COVID year. And it's almost something new that we learn. You think it's just a chest drain, and then an expert like Dr. Allard comes and Tobias, and then you feel, sure, where have I been around for the last few years? I learned so much. So from my side, Dr. Allard, Tobias, I really want to thank you for making yourself available and sending or spending your time. We know that a lot you are out of your practice, out of your job for this, and we really appreciate it. And I just want to disclose to the participants, we didn't pay Dr. Allard anything, so it's an independent opinion. And we really appreciate it, Doctor, that you are always willing to share your knowledge. You have a wealth of knowledge, you are a great mentor, and I really want to encourage some of the new users, if you are not sure about using anything, not just a snap chest rank, Dr. Allard is one of 45 trauma specialists in South Africa. He's been around a while. He has a website. He shared his email address. Please reach out to him. He's always willing to help. His heart is with his patients. He has a very passion for trauma. So, Doctor, thank you so much for sharing your knowledge again with us. Tobias, Tobias is working different hours because of different countries and different time zones. So Tobias is the one person in Zimbabwe that's working from 4 o'clock in the morning to about 9 o'clock at evening, depending on availability. So Tobias, thank you so much for sharing your knowledge with us, taking time. We know that you are away from your market and from your clients now, so we appreciate it. And Candice, thank you so much. Candice is National Sales right hand. She is National Sales Coordinator, and she's doing an excellent job. This was her first webinar that she arranged on her own, and she managed on her own. So Candice, you did fantastic. And then to all of our participants, without you, it wouldn't have been possible to have this webinar. And thank you so much for attending, making time for that. If you feel there's any of your colleagues that needs to attend, please share the link with them for tonight's session. Tonight is going to be a recording of this session, but we will take all the questions that's being asked tonight. We will then share it with Dr. Allard and Tobias, and then we will get back to them with the answers. So even though we don't have live speakers, we will definitely make sure that all questions asked will be answered. Thank you so much, and to all of you, I know this is your busy time coming up now with Christmas and New Year. We at Sinapi, we are closing on the 15th for our holidays. This is the only time in the year that we are taking a break. So we will be available, Candice, myself, we will be available on our cell phones. So please do not hesitate to call us if you need us. But may God bless you and your family over this festive season. May you be surrounded by his peace, by his love, by his compassion, and may he really revitalize you in your time of busyness with his strength, and guide you and protect you so that you can do the best and live out your passion, and that is to bring life and revive life to patients and their families. So thank you so much for such an excellent job that all of you are doing. You are the heroes of South Africa. You are the heroes of the world, saving patients' lives every day. And it's by God's grace that you are in that position, but you came and you are willing. So keep up the good work, and we are looking forward hearing from you and seeing you again in the new year. But like I said, Candice and myself, we are always there for you. Never mind what time, what date, if you need our help, we are there for you. Thank you so much. Dr. Allard, thank you. Have a good day, Tobias, thank you. And to all our participants, just a last note is you will get 1 CPD point for this activity. The new HPCSA system is we upload it to the HPCSA for verification, and they will send the email. So there's no more certificates that's being issued from our side. So you will get a confirmation email from the HPCSA. Thank you so much and have a good day. We will also, sorry, I forgot. We've got some articles as well that we will share for those of you that are interested. We will share the links. and you have an opportunity to get more CPD points by reading those articles. So we will share it with each and every one of you. It's your decision whether you want to participate in that or not. It's just an additional opportunity. Have a good day and thank you very much. I give back to Candice.
Wonderful. Thank you everyone for attending as well. And then also to our General Manager, Dr. Magda Botha. Ma'am, thank you for your time. She's taking the time away from our manufacturing plant to be with us this morning. And we also do really appreciate you. Thank you everyone and have a lovely day further.
Yeah, thank you very much, everybody. Have a good day. Bye.